Hi everyone, I'm Amer. I think I've met most people here. I'm part of the Global Health Division. I'm going to do a quick small talk today about penetrating neck trauma. Who here has not taken care of someone with a penetrating neck trauma? Nothing at all. Not even a poke. Not even like a kitchen knife. Nothing at all. All right, you'll see soon. All right. Okay. So starting on with the basic stats, they account for about 1% of traumatic injuries in the U.S. Mortality is high. The predominance is going to be gunshot wounds and stab wounds, which we see a lot here in King County. Keep in mind that the mortality in these patients is based on exsanguination, so up to 40% of patients. That's what happens. Think secondary to vascular injuries. Okay, so that's why you have to keep that in your mind the whole time. Up to 20% of these patients can have a hemo or a pneumothorax, right? So be looking for that in your mind, be looking for that in the patient as well. Just, some ABCs of how we think about these patients, right? As soon as they come in, what things you have to keep in mind in terms of the trauma mechanism itself, right? So we have to think about the anatomy, right? When we say anatomy, we're talking about the neck zones because that's what's kind of we've been using so far to figure out who is sicker. The vascular layers are continuous, so the injuries can track down into the mediastinum, right? So remember that if it's a knife, right? If it's a gunshot, if it's something, right? It's not necessarily going to go straight through. It can go up, it can go down. So keep in mind that what you see is not necessarily as superficial as what you get. The placenta, of course, which is what we always talk about with the trauma for evaluation, right? Sits between the superficial and the deep versical fascia, right? The reason we talk about the placenta is because of the fact that if it's injuries, then we think that there's an injury to the deep cervical fascia, right? That's why it's important. We all learn about the hard versus soft signs, and I'll talk about that in a few minutes, right? Anytime you have any hard signs or the placenta is violated, you have to assume a difficult airway, right? So always have the neck prepared for crico, okay? To be honest, always have the neck prepared, always plan for it anyways, anytime you see a penetrating neck trauma or any type of neck trauma. And the way to do that is basically identify your cricothyroid membrane, right? Maybe put a little X on it, maybe make sure you have your kit at the bedside so that you're prepared. Talk about it out loud with your bedside nurse so that you know, so that they know what you're thinking about, so that they know what you're preparing for. And that way yes, question already?
So just a couple things about the neck zones. Just don't forget these are anterior neck zones, not posterior. Posterior injuries are graded totally differently. And also injuries can cross zones. It may be a zone 2 and 3 or a zone 1 and 2. It's not just limited to one zone only. So when you have a entrance wound, don't forget that it could be into a different zone, even if it's in one zone for the end.
Thank you, Dr. So the zones were basically historically used for evaluation in the during World War II. Okay, and I'll talk to you about that in a few minutes. Zone 1 is from, so you go from down up to the head, right? 1, 2, and 3 go up to the head, right? Up to the cricoid cartilage is zone 1. Cricoid cartilage to the angle of the mandible, zone 2. The superior part of the angle of the mandible up to the base of the skull is zone 3. Historically, they the trauma side has been dividing the neck into the anterior and posterior triangles. The anterior triangle is basically delineated by the spherical emetotor. So in front of it is anterior, behind it is posterior, right? Keep in mind that the neck has a lot of critical organ systems running through it and critical structures that we need to keep in mind anytime we evaluate any of these patients for any of these types of traumatic injuries. Hard tines and soft tines. This is from the West trauma. Basically, hard tines are things that make you think that this is catastrophic, right? So airway compromise, hematemesis, neurodeficit, right? Bubbling of the wound. You're having massive subcutaneous edema. You're having brisk bleeding, right? Soft tines are not necessarily good. They're just a little bit less catastrophic, right? And the trauma literature says that vascular bruit or thrill are a soft sign, but both Tintinellis and Rosens, they list bruits or thrill as a hard sign, okay? So you have to keep that in mind. At the end of the day, really just evaluate the patient in terms of what you're seeing in front of you and the consequence of the injuries that you're noticing, and evaluate all of the critical organ systems that you can think of, right? Airway, breathing, swallowing, the air digestive tract, right? Any neurological deficits that can indicate posterior injuries. And based on that, you'll be able to remember what the hard signs should be. If you start with the primary survey, right, like any trauma, right, you're always running your ABCDs. ABCDs, as we're taught in med school, right, make you think that it should be A, then B, then C, then D. In reality, as you all see while we're practicing, they're really done at the same time together. So I'm doing A and B and C and D at the same time, and I don't stop for one to do the other. Obviously, if one of them has more severity, then I stop to address that one first, but in reality, I'm addressing all of them at the same time. Right? In a penetrating neck trauma, if you're unstable, you really should go to the OR right away, or angiography suite if angiography is the only thing that's available. The only thing that should hold you back from going to the OR is if you need to do emergent airway management. So if you only need to intubate the patient, that is the only thing that should hold you back. Not anything else, not the fast, okay? Try to minimize BVM because back valve basically can lead to dissection of the air through the neck tissue, and that can worsen the neck anatomy and distort your airway. So unless it's absolutely needed, you want to minimize it, right? If you see signs of a vascular injury, right, hard sign or soft sign, do not probe it, right? These injuries can become very unstable. The clot can dislodge, the hematoma can expand. So the only thing that you should do if you see signs of a vascular injury is direct pressure until you get to the OR, right? By direct pressure, we're not talking about a whole ton of gauze. We're just talking about 1 or 2 fingers precisely pointed to the site of where you notice the bleeding. That usually should control the site of bleeding that you're dealing with. If you don't get enough control with that and you have time, you can consider throwing in a Foley catheter and using a balloon to tamponize that bleeding, okay? Again, do not probe these injuries, right? Just apply hemostasis and send them to the OR. When you're thinking about IV access, you try to avoid the neck, you try to avoid the ipsilateral upper extremity until you can rule out a vascular injury for sure. So you try to go on the opposite side and you try to avoid the neck if possible. Right? Think about that also because as you're managing these patients in the trauma bay, you're going to have your nurse or your TPA or your tech trying to get an IV somewhere so that you can at least let them know, hey, please just don't use the right side, go over to the left, if it's possible. Be careful about placing NG tubes in these patients because if they have any injuries to their aerodigestive tract, so the pharyngeal esophageal tract, and you have a hematoma there, you can dislodge the clot, and that can worsen or destabilize the hematoma. So oftentimes, if there is a concern about an aerodigestive tract injury, so to the pharyngoesophageal space, you might be having to place an NG tube under direct visualization with endoscopy. Cervical collar, and I'm gonna give a plug here to Johnny's talk because I think it was really good. Just one more thing against the cervical collar is that it can obscure evaluation and interfere with management. As you can see here, the cervical collar is mostly designed to show you the anterior neck, right? It's just thinking about you being able to perform a cricothyrotomy, right? It is not designed for you to be evaluating the rest of the neck. And a lot of times these patients might come in with a C collar, they might not, right? The important thing is to evaluate the neck and check it thoroughly before you place a C collar on them, if you need to place a C collar on them. The reason why I'm saying this is because the data shows us that in patients with isolated penetrating neck trauma who are awake and neurologically intact, the incidence of a cervical spine injury is very, very, very low, right? It's not zero, but it's very, very, very low. These injuries are uncommon. This does not apply to blunt neck trauma, right? This is penetrating neck trauma only. And obviously, if you find for whatever reason that your patient is altered or there's a neurologic deficit on presentation, that could be a sign of cervical spine injury. And if that's the case, you need to place a cervical collar. Then what you want to do is evaluate the neck first. Make sure you don't miss any hard or soft signs of injury. Place the C collar, and if you do that, come back and reassess them later with inline stabilization. Take the collar off, check the neck again, inline stabilization, place the collar back again if you need to keep it on. If you need to keep it on. So now thinking about what we're going to use to start diagnosing the types of injuries that we would expect from a penetrating neck trauma. At this point, really, at least in most highly resourced countries, you will use a multi-detector CT angiography as the first line and the primary imaging modality for these patients. Traditionally, you'll see that you'll read about CT versus angiography. The disadvantages of angiography, obviously, is that it can't evaluate non-vascular structures, and like any type of catheter-related procedure, there's always the risk of a site hematoma, a dissection, thrombosis, embolism from that site. So CTA is really going to be your friend in these cases. The limitation of a CTA, obviously, is it can have freak artifacts that someone has retained foreign bodies, especially any metal or shrapnel, or the shoulders of very large patients. So always keep that in mind, but overall, it has very good sensitivity and specificity. You can supplement the CTA as needed with endoscopic procedures. So we're talking about flexible endoscopy, we're talking about bronchoscopy, we're talking about EGD. And sometimes, if necessary, you might need to do a contrast esophagram, even though you won't be using much of that here, at least, or practicing in any more resourced area, because you'll usually end up using more endoscopy with direct visualization with your ENT colleagues. If you have to do a contrast esophagram, gastrografin is preferred because it has a less risk of chemical mediastinitis in the case of actual leak. Ultrasound is great for clinically significant vascular injuries, but it's not going to be able to evaluate anything else, and it's going to be limited by the presence of air with subcutaneous emphysema, with a large hematoma potentially, and you can't look at intrathoracic or intracranial vessels because of the bone. So if you need to be in a certain environment where you're going to rely on ultrasound, just use it and keep in mind the limitations of that study. Plain films are really not going to be helpful. They can show you or suggest a perforation or pneumothorax, but they're not sensitive for anything else really in the neck. So CTA is your go-to and first-line imaging modality in this case. When we think about the kind of patterns of injury and the different areas we would expect to have injuries from penetrating neck trauma, there's three major areas, right? There's the laryngotracheal, right? Breathing and talking, right? There's the aerodigestive, right? Eating and swallowing, right? And there's vascular. Ask the patient, if your patient is awake, right? Ask them to cough to check for hemoptysis. Ask them to swallow their saliva to see if there's any signs of esophageal injury. Ask them to phonate to see if there's signs of a laryngeal fracture. These things can help you if you have the chance and time to be able to perform them with the patient, to be able to at least give you a hint as to what damage might be obviously critically, what structure might be obviously critically damaged. The reason why this is important is because specifically for pharyngoesophageal injuries, they can have a delayed presentation. Even though they're rare, they can have a delayed presentation. So you have to maintain a high degree of suspicion for them, and you have to consider that when you're reassessing these patients. If you suspect an injury to the aerodigestive tract, to the pharyngoesophageal tract, you should be giving these patients broad-spectrum antibiotics and cover for anaerobes early because it has been shown to reduce mortality in these patients. Vascular injuries, like we said, direct pressure plus or minus balloon tamponade. Laryngotracheal, if you're suspecting any damage to the larynx, you want to call your ENT colleagues to perform a flexible endoscopy. Remember that ENT do not come down with trauma alerts. So you would have to think about that and call them as an additional consult. The kind of culmination of all of this, right, gives you this kind of protocol that was designed by the Western Trauma Association. This is the most recent protocol that we have, as recent as 2013. There's the East and there's the West, but the West is more current. So that's the one that we're relying on. As you're looking at it and working through the tree, you'll notice that it starts off with the assumption of unstable injury or platysmal violation, right? If we have a scratch, right, that does not violate the platysma, this is not really part of this protocol, right? And that's why we have to examine these wounds thoroughly at the beginning to be able to figure out why we're doing the things that we're doing. Right? Like we said at the beginning, if you're unstable, you go into the OR. The only pit stop is if I need to manage your airway right away, right? If I need to intubate you, that's why I'm stopping. If you don't need intubation, you go straight to the OR. And you're better off getting intubated in the OR anyways because you likely will have some type of distorted anatomy. So unless I have no option but to stop and intubate you right then, you're better off going to the OR. Pathway C, I doubt you'll rarely see it being used here or anywhere in this country because it's just not something that I can imagine trauma surgeons being comfortable doing if someone has a platysma injury. So you're mostly gonna run down the bottom of the tree. And all roads lead to CT angio, as you can see. The important thing here is to think a little about the history of how we evaluated these penetrating neck traumas. And this is where I'm going to talk to you about the whole idea of neck zones. So during World War II, they started realizing that in the battlefield, they were losing a lot of soldiers to these neck wounds. So they had to figure out a way to try to figure out who was sicker and who needed immediate exploration and who could have selective exploration. So that's why they were using this zone 1, zone 2, zone 3. Zone 2 was thought to have the most critical vital structures. So if you had a trauma to zone 2, that's what really prompted your mandatory evaluation, right? With time and with the advent of multi-detector CTA, and the reason why I'm saying multi-detector CTA, because it's not like regular CTAs, right? This is what we use here. But just in case you're somewhere else, you're in another country, you have to ask what type of CTA you're using because there's a difference between the thinness of the slices and the exposure that the CT can give. Over time, they realized that combining these types of protocols with a multi-detector CTA, which has a roughly 100% sensitivity and 97.5% specificity for critical injuries, was able to give them a more selective approach for the hemodynamically stable patients. Again, Hemodynamically unstable, you're going to the OR. No questions asked. Right? Hemodynamically stable, the trauma paradigm has now shifted to more of a what they call a no-zone selective exploration approach. So there's no mandatory exploration for anyone who's hemodynamically stable. They try to stop by CTA first, and then they figure out based on that who needs to get explored, and that's led to a reduction in the amount of formal neck explorations that they've had to perform. Now, obviously, the end of this tree is still missing something, right? Which is distal, and that's what we have to think about is EM ducts, right? So none of these patients are going home, right? If this patient has to go to the OR, then they go to the OR, right? If the patient has a platysmal violation and their workup is negative, they get admitted to trauma for observation, right? These patients need to get observed because of the propensity for these injuries to get worse over time, for the propensity for delayed pharyngeal esophageal injuries, like we said before. So always keep in mind that these patients need to be observed with the trauma surgery team. If you're not at Kings County, if you're not at an urban center, if you're not at a trauma center, you need to be getting these patients to a trauma center ASAP, right? This is not the patient that you keep in your ED and you try to work it out with your run-of-the-mill general surgeon, right? They need to be in a trauma center. So you do your ABCs, right? And if you can stop anywhere where you stabilize the patient, that would be the time for you to send them to a trauma center right away, if you can, right? That's a 911 transfer, of course. If not, then you do what you can, keep the patient there until you can stabilize them to your best abilities, and then you ship them off to a trauma center. These are things also to keep in mind in case you're practicing in any scenario where you're not, let's say you're not here, you're abroad, you're practicing globally, you're practicing somewhere in a scenario where you might not have easy access to surgical centers. It would be important for you to know where these patients will go later on. So special considerations, right? Pediatrics, always difficult, always scary. The important thing to remember about peds is that because of the fragility of their airway, they can have a propensity to have more edema and more hematoma expansion, so they're more likely to come in respiratory distress, right? Their airway is a little more anterior and a little bit higher, okay? But otherwise, their management will mirror that of the adult trauma patient. The only difference is cricothyrotomies are contraindicated in patients less than 10 years old because the larynx is not adequately developed, so there's a risk that you might fracture the larynx. So if that's the case, you might need to perform a transtracheal jet insufflation. For the anticoagulated or hemorrhagic patients, consider MTP. Obviously, for anyone who's suffering from a massive hemorrhage from a traumatic injury, you're considering MTP, right? TXA, Kelsey pretty much said everything that I was going to say. So consider it, right? Now you know about the CRASH 2 trial, you know about PAT 3, you know about PAT. Don't be surprised if trauma surgery wants to give it, not a problem, right? Especially since there's very little harm and you would expect that these patients are going to die from exsanguination. So that's actually a point to that. To wrap this all up, be prepared for front of the neck access, right? At all times. Be prepared for it, especially if you see hard signs. Think about it, even if you don't see hard signs, so that you're not surprised if hard signs develop later during your evaluation. Try to minimize back valve mask ventilation, right? Do not probe bleeding wounds. This is not indicated. Look for the hemo or pneumothorax that's present in about 20% of patients. Don't just think about the neck. Remember, the fascia is continuous, so any injury can easily spread down to the mediastinal area. IV access, if you can get it on the contralateral side and avoid the neck, because you have to assume that there is a vascular injury on that side. If you suspect injury to the pharyngoesophageal tract, to the aerodigestive tract. You need to be giving these patients broad-spectrum antibiotics early and cover for anaerobes to decrease their mortality. Remember that a lot of, or the majority of patients with heart signs will have some type of injury requiring repair. So if you're not in a trauma center, you need to be sending these patients to a trauma center ASAP. If you are, you need to be activating a trauma alert and calling your surgeons down as soon as possible to have them get taken to have them at least be prepared to get taken to the OR. And if you're hemodynamically stable with a platysma violation, you're getting a CTA plus or minus flexible endoscopy, bronchoscopy, EGD, depending on the direction that we think this injury has moved to. And these are my references.